Thank you, sir. Thank you for the opportunity. So selecting the quadrant for implantation of the episcleral plate of the glaucoma drainage device is vital. And the most preferred location is the supratemporal quadrant, ensuring that there is adequate conjunctiva and tenons for good closure. On certain occasions, due to some anatomical impediments, like you have a staphyloma in the supratemporal quadrant, or you need to plan a repeat tube, usually the next quadrant of preference is the superior nasal quadrant. Sometimes the whole of the superior quadrant is compromised by in this patient by a trauma with ciliary staphyloma. So you need to go inferiorly to place your tube to manage the refractory glaucoma, and usually we prefer to have it in the inferior nasal quadrant. Also, if you need to plan a repeat tube where the superior nasal quadrant is compromised, again the quadrant of choice is inferior nasal. Another important tip is that your end plate of any glaucoma drainage device has to be 9 to 10 millimeter posterior to the limbus. All those anteriorly placed episcleral plates have huge potential to create complications. And always try to stick to a single quadrant. See, everything has gone wrong here. It's not in the quadrant, it's placed superiorly. The wings of the non-valved implant has to be positioned beneath the muscles. The wings are outside. The anterior edge is migrated forward. There is a longer than adequate length tube in the anterior chamber. Again, use of 3-0 supralon suture for intraoperative stenting of non-valve devices have made the surgery much more safer. You use the intraoperative supramid stenting, and you have those 6-0 vicryl ligature sutures, one above the stent supramid and one beyond that. So temporary occlusion of the tube is vital in non-valved implants. Usually the fibrous capsule has to form well above the around the episcleral plate. This usually takes about 5 to 6 weeks, and by that time the ligature suture dissolves and the tube patency is established. Again, with the advent of this supralon suture, which is now freely available, chronic hypotony was an issue with non-valved implants, and an ab interno supramid stenting has definitely made life much more easier. There is something really predictable to take care of this chronic ocular hypotony seen in a very late stages of, especially with a non-valved implant. You could use it even if you have a hypotony with a valved implant. Also, you could use this procedure. So this is a 2.2 bevel up keratome entry into the anterior chamber. We usually prefer to have these keratome entries rather than your sharp paracentesis. These seal off much better. So this is the multi-filament supralon suture. The competitor brand is the Supramid suture. So this is the multi-filament. This is 3-0 nylon, and usually we measure approximately the corneal diameter to do this ab interno stenting. So it's around 11.5 millimeters, and a sharp bevel is made on one particular end, and this can be easily guided into the lumen of the tube through a paracentesis about 180 degree away from the position of the tube. So now here we are not touching the conjunctiva. Earlier we may have to open up the tube, open up the area of the conjunctiva near the tube, ligate it 6-0 vicryl. And this has also been published, and it's a definite way to take care of your chronic ocular hypotony seen many years after implantation of the glaucoma drainage devices. That is a microrhexis forceps which is being used to guide the supramid into the lumen of the tube. Again, tube position in the anterior chamber is critical. You just cannot see on a cursory glance, this looks like everything looks fine. But here, see, if you make a slit, the slit on the tube is very close to the slit on the cornea, and the slit and the distance between the iris and the tube is much more than what is actually ideal. It should be as close, and no wonder over a period of time the cornea started decompensating. It just cannot be left close to the endothelium. Uh, you have to find ways to make sure that the tubes are positioned as close to the iris intraoperatively, and it should be. And if you make a slit right from the entry into the anterior chamber, this distance should be maintained. Distance from the cornea, the slit on the cornea, the slit on the tube, and slit on the iris. If you see very carefully, see this distance and compare the distance from the tube to the iris. Find ways to make it work in your hands. Uh, this is a 3 millimeter distance. We usually find that if you dip into the anterior chamber, you go into the scleral tract, and if you dip between this 2.8 and 3 millimeter, usually you get a good position of tube in the anterior chamber. Also, some precise measurements, like you drape the tube over the cornea, measure 2 millimeter, make an anterior bevel, and if you position this tube 2 millimeter medial to the initial position of the tube, you get an adequate 2 millimeter length of the tube in the anterior chamber. Initially, we were always worried about these long tubes, short tubes. And we also found that having a sinuous route like this, secondary interventions, if we had to see, this was the tube which was very close to the cornea, we had sufficient length of the tube still available because of the sinuous route to reposition it back into the anterior chamber at a different position. Here was a tube retraction, again repositioned without the use of a tube extender or other tube extending devices. A note that shallow ACs are common even with valved implants. Mild choroidal effusions can cause shallow ACs. Usually, with conservative treatment, most of them form well. But here was a patient, this was the third day post-op, fifth day post-op, still shallow AC, provided the B scan doesn't reveal any hemorrhagic choroidals and the pressures are still low. Keep this in mind that you might, a valve malfunction is possible with an AGV, and you might have to go and ligate the tube to to get the chamber formed. Tube exposures rarely occur 4 millimeter beyond the limbus, and burying the tube in the patient's sclera for this 4 millimeter is sufficient insurance against tube exposure, which is usually a big headache for the glaucoma surgeon. One last point about the hypertensive phase. Usually occurs after the tube ligature dissolves in non-valved implants. It's much later than in the AGV, where it usually occurs in between 4 to 6 weeks. Tenon cyst encapsulated blebs are much more common with the valved implant. It's extremely important to start aqueous suppression right at the immediate post-op. If the pressures are 10 millimeters or above, we just start a fixed drop combination from second post-op day in AGV, and also continue the fixed drug combination in a non-valved implant after 6 weeks after the ligature suture is opened up. The inflammatory mediators reach the subtenon space much less with aqueous suppression, and chances of these bad encapsulations are less. I just want to conclude saying we still do not have the perfect GDD, but a lot of work has gone into the intraoperative surgical technique to ensure that many of these patients' useful vision is preserved at sometimes even with a multiple GDD. Thank you very much.